This recording will go over Chapter 40, The Child with Fluid and Electrolyte Alteration. We're going to focus on dehydration, diarrhea, vomiting, and rehydration. Characteristics unique to infants and young children make them more vulnerable than adults to fluid and electrolyte imbalances. Under normal conditions, the amount of fluid ingested during a day should be equal to the amount of fluid lost through sensible water loss and insensible water loss. Please refer to the box at the beginning of the chapter that indicates the differences between pediatrics and adults regarding fluid and electrolyte imbalances. Because infants and younger children have a higher proportion of extracellular fluids than older children and adults, they are more susceptible to rapid fluid depletion. In regards to infants, they have a higher percentage of water and extracellular fluid. They are less able to concentrate urine because of immature renal function. They have a higher rate of peristalsis. They have immature lower esophageal sphincters, making them more prone to gastroesophageal reflux, which can lead to dehydration and electrolyte disturbances. Infants have a harder time compensating for acidosis because of their decreased ability to acidify urine. In regards to infants and children, infants and young children have a higher metabolic turnover of water relative to adults because of a higher metabolic rate. Infants and young children are unable to verbalize or communicate thirst. Infants and children have proportionately greater body surface area in relation to body mass, resulting in a greater potential for fluid loss through the skin and GI tract. They have higher proportionate water content. The immune system of infants and children is not as robust as an adult's immune system, rendering young children more susceptible to infectious diseases, fevers, gastroenteritis, and respiratory infections, all of which can result in fluid and electrolyte disturbances and fluid volume deficit. Finally, infants and children are at a higher risk because of increased exposure to infections in a daycare or nursery setting. Dehydration or fluid loss and excess of fluid intake results most frequently from severe gastroenteritis and is one of the most common causes of hospitalization in infants and children. Decreased fluid intake or increased fluid loss can cause dehydration. Dehydration produces both fluid and electrolyte deficiencies. Dehydration is classified as isonatremic, hyponatremic, or hypernatremic, according to the status of the serum sodium concentration. And ISO, so with the term ISO or the prefix ISO, you should recognize that as meaning same. So in isonatremic dehydration, the most common type of dehydration in children, water and electrolytes are lost in approximately the same proportion as they exist in the body, and serum sodium levels remain within the normal. In hyponatremic dehydration, the electrolyte loss is greater than the water loss, resulting in a low serum sodium level. In hypernatremic dehydration, the water loss is greater, resulting in an increase in serum sodium levels. Dehydration has many causes. Common alterations that can lead to dehydration include gastrointestinal tract issues such as vomiting, diarrhea, pyloric stenosis, and malabsorption, endocrine system issues such as fever, diabetes mellitus, and cystic fibrosis, burns, tachypnea, renal, or heart failure. Children of any age can be affected, but neonates and infants are especially vulnerable to the effects of dehydration. Classifications of the severity of dehydration vary according to published source. In general, for infants and young children with isonatremic dehydration, the fluid deficit is described as mild, moderate, or severe, depending on the percentage of body weight loss. For mild dehydration, less than 5% body weight is lost. Moderate dehydration would result in 5% to 10% loss of body weight, where severe dehydration is greater than 10% loss of body weight. 1 milliliter of body fluid is approximately equal to 1 gram of body weight. So a weight loss of 1 kilogram in 24 hours represents a 1 liter fluid loss. So you should already know that 1 liter is equal to 1 kilogram. You can make it even smaller and memorize that 1 milliliter is equivalent to 1 gram. The signs and symptoms associated with degree of isonatremic dehydration are listed in Table 40.2. Please review that table on your own. As with impending shock, the most essential manifestations are changes in heart rate, general appearance, behavior, or sensorium, urine output, skin and mucous membrane qualities, and in infants, sunken or depressed fontanelles. In infants and children with moderate to severe dehydration, decrease to absence of tears are a sign of dehydration, but lack of tears is not an accurate sign in very young infants who might not produce tears until approximately 2 to 3 months of age. Because of the child's ability to compensate and maintain an adequate cardiac output, changes in heart rate, sensorium, and skin color are earlier indicators of impending shock than is blood pressure. Key factors to consider in determining the type and severity of dehydration in children include a history of acute or chronic fluid loss, clinical manifestations, the child's weight, and serum electrolyte values for moderate and severe dehydration. An elevated urine-specific gravity suggests dehydration. Therapeutic management is directed towards correcting the fluid and electrolyte imbalance and then treating the causative factors. Please review Table 40.3, which reviews oral replacement and rehydration therapy for children with vomiting or diarrhea. In terms of children who have minimal dehydration, treatment of minimal dehydration consists of continuing breastfeeding or age-appropriate diet, along with fluid replacement for an episode of fluid loss, such as stool or emesis. Regardless of the child's age, fluids are replaced with an oral rehydration solution, such as Pedialyte. Oral rehydration solutions have changed from the days when parents would make their own homemade recipes of water, salt, sugar, and cereals. Today's commercially available rehydration solutions are lower osmolality fluids. Because of their osmotic effect, the higher carb content in fluids such as apple juice or colas may further aggravate diarrhea and cause additional fluid loss. Electrolyte or sports drinks like Gatorade have been accepted as rehydration formulas for older adults. However, recent studies suggest that these sports drinks are not the best solution for rehydration and may in fact worsen diarrhea because of their high percentage of sugar and carbs. These supplements greatly increase the osmotic load in the intestines and further would aggravate diarrhea. For children with mild to moderate dehydration, treatment of fluid and electrolyte imbalances in children with mild to moderate dehydration should include rapid oral rehydration therapy with an oral replacement solution in addition to replacing fluids lost during episodes of vomiting or diarrhea. Suggested rehydration for children with mild to moderate dehydration is 50 to 100 mLs per kilogram of oral rehydration solution over 3 to 4 hours, with evaluation of the child's hydration status at least every 1 to 2 hours. Breastfeeding infants should continue to breastfeed during oral rehydration. An age-appropriate diet should be offered to all other children once hydration status has improved. If the child is severely dehydrated or unable to take fluids by mouth and continuing fluid replacement is needed, parenteral fluid and electrolyte therapy is initiated. Initial therapy is aimed at treating and preventing shock. Either lactated Ringer solution or normal saline is the fluid of choice for parenteral rehydration and restoration of circulation. Both the CDC and the World Health Organization recommend providing oral rehydration simultaneously with parenteral rehydration as long as the child is alert enough to drink. If not, oral rehydration should begin as soon as the child becomes alert. The type of dehydration determines the rate of administration of replacement fluids. Please review box 40.1 in regards to maintenance fluid requirements and minimum urinary output. Please review the purple nursing care box for the child with dehydration on your own. Signs and symptoms of dehydration can include fewer wet diapers, especially no wet diaper for more than 6 to 8 hours. No tears when your child is crying if older than 2 to 3 months. The inside of the mouth being dry or sticky. Irritability or a high-pitched cry. Difficulty awakening. Increased respiratory rate or difficulty breathing, a sunken soft spot, sunken eyes with dark circles, abnormal skin color, temperature, or dryness. Because a young child's condition may worsen faster than an older child's, Seek professional assistance earlier if your child is younger than 6 months of age.